You will not believe what I just found in a published paper just done yesterday, looking at the benefits of a new drug, well, not a new drug, semaglutide, and protection from heart disease. How in the world did I get this connected to a question mark about vax risks in the heart? I'll have to show you in just a few minutes. So you better listen to this because this information is not available anywhere else. Now, let's be clear. This is my analysis. This is me looking at the data. It's not necessarily what the authors have published and what they want you to focus on, but it's certainly what I have been focused on and what I'm looking for when I prepare for what is this COVID storm. I am anticipating that things are going to get rough and that there's going to be a link to cardiovascular disease. So let's get straight into the questions and what it was that really happened. So you have to understand, and I've got this article here. So this article was just published just on the 30th of August 2024. Weight loss drug linked to fewer COVID deaths. And they were talking about this weight loss drug, Wegovy or semaglutide, which they found reduced risk from COVID by a third and reducing significantly the risk from cardiovascular disease or any other cause. And this was done by a Novo Nordisk. And critically, this is the important bit to note, is that from October 2018 through to March 2023, they studied the effect of giving it weekly versus placebo. And now you have to remember the trial started before COVID-19 and they never anticipated a global respiratory pandemic. So this is really valuable, clean data. What I mean by that is that it is not caught up in any narratives. It's just focused on clean data before the pandemic, not related to anything else. The question is, what did it show? And why am I talking about cardiovascular risk? Because they have talked about the fact that this drug seems to have reduced cardiovascular risk. So it's an important point for us to try and address. What really was it that they were looking at? So when we look at the paper itself, and you can see here again, this is published just recently. And you can see here that this is the paper here, the effect of semaglutide on mortality and COVID-related deaths, and an analysis from the SELECT trial. And again, you can see the date here, published August 30th, 2024. So this is hot off the press and a really important study for the drug because they want to promote it that it is able to protect against cardiovascular death. So they sought to assess the effects of this drug on cardiovascular deaths and non-cardiovascular deaths, including deaths from coronavirus. So this would have been added after the trial had started, because when they pulled it together, this was not yet available. They wouldn't have known about COVID-19 coming up. So let's just think about what it was that they were doing originally. And again, you have to think about their inclusion and exclusion criteria. And so I went and I got the clinical trials. This is what they have to publish in order to get their study on. And so this is the original analysis, clinicaltrials.gov. And they were looking at the time effects on heart disease and stroke in patients who were overweight or obese. That's the SELECT trial. And if you notice carefully, it was started here. This is the in 2018, the 24th of October, 2018. And it was completed here on the 29th of June, 2023. And what I usually am interested in here is who is eligible for it. And you can see here the eligibility criteria. Male or female, you must be at least 45 years old. Your BMI, your body mass index, must be equal or greater than 27 kilograms per meter squared. And critically, you have to have established cardiovascular disease. So this is not a normal population. This is a population who already has cardiovascular disease, prior heart attack, prior stroke. And as usual, they have a number of exclusion criteria. They look at people who haven't had it within 60 days. They look at the blood sugar, general history, safety stuff. So, all standard stuff that they would have done in order to get this study ongoing. So, as I said, this was started in 2018. And so, therefore, it was prior to the pandemic. So they were talking about the benefit that this drug has with regards to protecting against cardiovascular mortality. That's where it gets interesting because, again, my question is okay, it protects against cardiovascular mortality. Did you anticipate that? Was that what you were expecting? And my question is always in the back of my mind, how does this relate in terms of the pandemic, and especially the question about cardiovascular issues around COVID vaccinations? Because it seems as though there's lots of data out there that doesn't quite all add together. So, what really did this show? So, I'm going to highlight a few points here from the paper itself again. So, let's look back at the paper here. So, again, this is the analysis from the select trial and their objectives. Again, they were looking at on all cause deaths, cardiovascular deaths, and non COVID deaths. And they see here the most common cause of cardiovascular death with semaglutide versus placebo were sudden cardiac deaths and undetermined deaths. And so this is where they found that there was a significant benefit with regards to the participants who were using semaglutide. So, my question again is well, how did this play out in the context of the pandemic? And this is where now it gets very, very interesting. And when I looked at the data, and I have to say that I looked at it initially, just looking through objectively, just to see a picture, something stood out to me. And that's really what I jumped on. So I'll show you the not so worrying bits first, and then I'll show you the bits that I was really interested in. So here we have this is comparing semaglutide and placebo. And this one here is looking at COVID-19 deaths. This is C, event rates. And you can see they're going all the way from 2019 all the way to 2023. And you can see here, placebo seems to be higher than semaglutide. They come down together. Nice. It fits. It seems to fit. So there does seem to be some protection. And they have this bar here to represent the pandemic period, which they've picked up to early 2022. And that seems to make sense. When we go a little bit further on, now this is looking at non cardiovascular related deaths. And again, this is semaglutide in blue, a placebo is in orange, and again it's higher. So there does seem to be some protection, but they're again trending together. And they seem to think, the authors, that this was relevant in terms of event rate. So there seems to be some degree of protection, nothing out of the ordinary. But let's go on further. This is what really caught my attention. This is cardiovascular deaths. And you can see the box here is the pandemic. And you can see them going along. And again, this is early in the trial. Orange is the placebo, blue is the semaglutide, and they're plodding along fine. They start to diverge around here. And if you pull down, that's just late 2021. And then by the middle of 2022, wow, this then happens where there is now a huge difference between the semaglutide, which is literally plodding along as normal, stable, but this just shoots off. Now, this is where this caught my attention because I thought to myself, that's not normal. I wouldn't have expected that. That's relevant. What does it mean? And that's where the question comes in. And I think that because the data is clean, it makes you think carefully about, well, what does it mean? Now, it seems as though this was a problem for the authors because they did try and answer it. They noticed it as well. And so they put in a few comments that I think are interesting, and I'll read them out to you here. So, what they said is that there are several limitations to their analysis. According to the pre specified testing, all comparisons following the cardiovascular deaths should be treated as hypothesis generating because cardiovascular deaths did not meet the pre-specified p-value. But now I have a problem because they're saying that it produces benefit, but now they're saying that it doesn't produce benefit. What are they saying? Moreover, testing subgroups and different components of endpoints can result in underpowered analysis and chance findings. So they are now trying to say, well, maybe this was just a chance. Although there's a possibility of misclassifications, the likelihood of such errors influencing the results is minimal because investigators and adjudicators were blinded. It almost seems as though they're confused. What is going on? Why are they saying that it is hypothesis generating, but it isn't necessarily relevant? It doesn't seem to add up. So, going on a little bit further, they say here that deaths during the COVID pandemic times were at times more challenging to adjudicate because of limited medical information. However, unknown deaths were conservatively categorized as cardiovascular deaths, and it should not have led to any treatment bias. So again, the point is that they seem to be a little bit confused about what their results are saying. It seems to me that there is benefit with semaglutide. It seems to be protective against cardiovascular risk after the pandemic. So the point is, pre-pandemic, it looks as though it was stable even during the pandemic. But somehow, after the pandemic, it changed significantly. What changed? That's really the question. And you have to understand, I keep on saying to people that what I'm looking for is the COVID storm. I am looking for the fact that when you have spike protein from any source, you can then have all kinds of strange patterns that are occurring. And that's what I call the COVID storm. And this is where I think that it's really important to try and see if we can get an understanding of what is going on. So, again, I'll just take you through a few steps for you to understand what I'm talking about with regards to the COVID storm. Here we have, and I'll make this big. This is the same slide that I've put on my slide. And again, as I showed you, the placebo is in orange and the semaglutide is here in blue. They seem to be stable in the pandemic region period. In effect, there may be a slight increase towards the end of the pandemic. But here we suddenly see a massive jump, and this is jumping to about 1.4 time event rate versus a start point of 0.7. So this is almost a 100% increase. I don't see how this can be irrelevant. And as I said, the semaglutide seems stable. It seems to have held that. So the question in my mind was why? What would be the mechanism based on what I'm concerned about with the COVID storm? Well, here is my thought. Whenever you have uncontrolled inflammation in the body, it leads to a cytokine storm. This is what happened in severe COVID-19. My feeling is that we're still having some form of a cytokine storm. It's just not primarily affecting the lungs. Here is where I think it's relevant with regards to macrophage activation. And I'm literally putting a paper together on this. And there's a course in the link in the description below. But macrophages, one of the types of white blood cells, quite versatile, are normally controlled by all of these other cells. This is the natural killer cell, the B regulatory cell, myeloid derived suppressor cell, M2 macrophage. But whenever you have infection or I should say any source of spike protein, what seems to happen is that two of them get dysregulated. The natural killer cell, which is absolutely critical. And so, therefore, you're more likely to have macrophage activation. Macrophage activation is what is associated with plaque disease. And so, this is why I am very interested in anything that can impact on macrophage activation. And absolutely right, when I did the check, semaglutide has an impact in stabilizing the inflammatory response around macrophage activation. It's one of many things that can do that. And this is why, as I said, I keep on encouraging people to learn about the COVID storm. I have the link in the description for the video. Take a look at it, because this is essentially what I'm looking at, how to stabilize it, what I call the 4 pillars. And if you join the newsletter, you'll get access to the video. So please click on the link below. This is how I approach the science around what is going on. So it doesn't surprise me then that semaglutide could be protective, or in terms of that COVID storm, which is why you would have seen an increase in the placebo group, but not in the semaglutide group. That's my thought on the matter. And it was very interesting that they were able to put lots of suggestions as to why this could be so. But when I search the document, what I usually do, a control F, type in vaccine, vaccination, absolutely no words. It's not even a possibility. Now, whenever I see that occur, I know that there is bias. Because how? When you look at the chart, and I have to bring it up again for you to see it, is when you look at the chart, I cannot think that there is any objective scientist who would be able to tell me categorically that this should not be in the picture. Just look carefully. Think about it. This is the pandemic period. It's relatively stable. This is my word, not theirs. And then towards the end of that, it suddenly diverges. In this period would be when we had done that large elephant in the room. Why would you discount that as a potential contributor to what happens here, especially when you know that things like myocarditis, pericarditis are part of the picture? I just don't understand it. It seems to be a scientific blindness that is occurring, and it has direct relevance to what's happening to people around us. We are at the point of needing to find solutions, finding mitigation strategies. And so, what we want is for us to look carefully at what is happening. And so, as usual, we always give you ways to support us. Remember, we also have our Kickstarter program, which is ongoing, and you can take a look at it here. Disease X, are you prepared? And we're trying to do a book taking on very many points that are relevant, because I think COVID is technically the disease X. I think that it is really where we're going to be challenged. So you can support us in that way. And additionally, if you want to support, we have membership on YouTube, we have Substack. You can look at the information. There's so many ways to support this research, and we appreciate it. And we appreciate the fact that our work to inform you is of value and something that's very important, because where else would you get independent, objective questions about what was happening? So, the main point is this: it does seem that there is evidence that this drug can help in terms of protecting, but is that evidence related to the fact that it stabilizes the cardiovascular system against damage from other sources of spike protein? That really is the question that I think needs to be answered. It may be inconvenient. It may not be what the scientific community wants to look at, but there is a responsibility to look at all the evidence, especially clean data, and to make a clear analysis. It's not difficult to break out that group. They have all the information on them. They could actually dissect it based on vaccination status and clarify that. That would be logical. Do a secondary study, give an answer, look carefully at it, make a clear review of what was happening. Let's hope that the scientific community does ask the hard questions, because otherwise, there are no opportunities for mitigation. Have a great evening.